Okay.
Good evening, sir.
Nice. Meeting is now streaming live on YouTube. शुरू हो गया?
Sir, some people have called me, sir, asking that they have not got the YouTube link, sir.
No, it will be started. You just put it in the WhatsApp group.
Yes, sir.
Okay?
Okay, sir.
Because once we start, it should be live. We can't just keep talking something and have on YouTube. Okay?
Yes, sir. Yes, sir.
8:55, Dr. Keshav Murthy, start introducing and welcome. Okay? Keshav?
I think वो थोड़ा बाहर गया है.
हाँ, कोट गेट पहने गए हैं.
Sir, I will share the YouTube link in our chat box, sir. If you want to share, you can copy it and share it, sir.
No, you are making it to whole whoever has registered. No, it is open now because they
Yeah, now it's open now, sir.
Then it's fine.
Yes.
Okay. 8:55, Dr. Keshav Murthy. I just saw your name and then things went. All others, please unmute except the one who are going to speak, especially just to avoid the disturbance.
YouTube link is not still open, na, sir. We are going to open it at 8:55.
Hey, or Rakesh?
Sir, it's open, but it's not recorded now.
Not yet recorded. It is open now.
Because when I click on the link, it says this web page is not found. Is it correct? Correct?
Sir, it is open. I guess what YouTube link I have, I'll share it with you, sir. Because I opened it in another this thing, it has started.
No, but then Nihar, the link which has been provided to the delegates, is it not the same link?
Sir, on the mail which I have shared, it has come the same link which I'm sharing.
Mail means everybody has got the same mail.
Yes.
No problem.
Because when I try it on my phone, the clicking that link says the page is not available.
Okay. Rakesh, please check it. Salman, you just check.
Swapnil sir, now the link which I have shared, if you can try that, because that has come who has subscribed, who has registered on their email, this link has come.
But this
sir, first you sign in the Gmail first, then it will link will be working fine.
No, but isn't it the same link which is being provided by Inamdar, sir?
Yes, sir.
But this has been opening up, but when I try to my phone, it says it is not available. Oh, you have to sign it through Gmail, right?
Yes, sir.
Okay.
Sir, the YouTube link is live, sir. I can see it and it is showing that it's live, sir.
Okay, Salman, if somebody asks you, just tell them you have to go through Gmail or something, whatever.
Yes, sir, I will tell them.
I will do it. I will copy this link and send it through WhatsApp.
Okay. Keshav Murthy.
Yes, sir.
8:55 should start.
8:55. Okay, sir.
So that 5 minutes introduction and all those things. 9 o'clock sharp, we will start the journey.
Yes.
Ajit, you are joined? Unmute.
Yes, sir. Yes, sir.
Good.
Yes.
Salman, please check with others if they are missing anything. Please try to help through Rakesh. Okay?
Yes, sir. I'll do it, sir.
Okay, Rakesh, at 8:55, sir will start.
Sure, sir. I will record it, sir, that time.
Okay. Okay. All the best to all. Chalo.
Yes.
Thank you.
ರಾಕೇಶ್ ಏನ್ ಹೇಳಿದ್ದು ಇದು ಲಿಂಕ್ ಜಾಯ್ನ್ ಆಗ್ಬೇಕಂದ್ರೆ ಜಿಮೇಲ್ ಅಂತ
ಹಾ ಸರ್, ಜಿಮೇಲ್ ಲಾಗಿನ್ ಆಗಿರ್ಬೇಕು ಸರ್, ಅವಾಗ ಯೂಟ್ಯೂಬ್ ಚಾನಲ್ ಓಪನ್ ಆಗ್ಬಿಡ್ತದೆ ಸರ್.
ಅದು ಲಿಂಕ್ ಒತ್ಬಿಡ್ರಿ ಸರ್, ಚಾಲು ಆಗ್ಬಿಡ್ತದೆ ತಾನೇ.
ಹಾ, ಲಿಂಕ್ ಮ್ಯಾಗ ಒತ್ಬಿಡ್ರಿ ಸರ್, ನೋ ಪ್ರಾಬ್ಲಮ್.
ಇಲ್ಲ ಒಬ್ರು ಯಾರೋ ಏಕ್ತಾ ರೂಮಿ ಅಂತ ಯಾರೋ ಕೇಳಕತ್ತಾರ ಫ್ರಮ್ ಪುಣೆ.
ಈ ಆಕ್ಟಿವ್ ಅದ ಅಂತ ಹೇಳ್ಬಿಡ್ರಿ ಸರ್.
ನಾ ನಿಮಗೊಂದು ಲಿಂಕ್ ಕಳಿಸ್ತೀನಿ ಸರ್ ಈಗ ವಾಟ್ಸಪ್ಗೆ, ಅದೇ ಶೇರ್ ಮಾಡ್ಬಿಡ್ತೀರಿ ನೋಡ್ರಿ, ಇಲ್ಲಾಂದ್ರೆ.
ಹಾ ಕೊಡ್ ಕಳಿಸ್ ಪಾಪ ಅವ್ರಿಗೆ.
ಎಸ್ ಸರ್.
ಈಗ ಕಳಿಸಿ ಬಹಳಷ್ಟು ಮಂದಿ ಕೇಳತ್ತ, ಒಂದ್ 3 ಮಂದಿ ರೀ. ಟೈಮ್ ಆಯ್ತಲ್ಲ ನೋಡ್ರಿ. What link he has sent, it is already on. Okay.
ಸ್ವಲ್ಪ ಲಿಂಕ್ ಕಳಿಸ್ಬಿಡ್ರಿ ಸರ್, ಇದು ಹಳೆ ಲಿಂಕ್ ಅದ.
ಯಾರಿಗೆ?
ನನಗೆ ಕಳಿಸ್ಬಿಡಿ ಸರ್, ಅದನ್ನು ಬೇರೆ ಗ್ರೂಪ್. ಹಾಂ, ಇದೆ ಸರ್ ಗ್ರೂಪ್ನಾಗ.
ಈಗ ನಾಯಕ್ ಕಳಿಸಿ ನೋಡ್ರಿ.
ಹಾಂ.
ಓಕೆ, ಸ್ಟಾರ್ಟ್ ಮಾಡಿ. Yes. Start.
Is it live now? Shall I start?
Yes, sir.
Start.
A very good evening to everyone and a warm welcome. I am Dr. Keshavamurthy Adya, currently heading the Department of Dermatology at Shri Patil Medical College, Vijayapura, Karnataka. Our department was instituted in the year 1986 along with the inception of our medical college, Shri Patil Medical College Hospital and Research Center. And the PG courses in our department began in the year 2005. And since then, we have made a lot of advancements and a lot of achievements. And we are currently recognized by the university as the Dermatology Center of Excellence in the northern part of Karnataka. And we are very proud to be associated with DECA Lasers Italy. And in collaboration with them, we have established the BLDE DECA Laser Academy, that is BDLA, under the directorship of Professor Arun Inamdar sir. This academy was formally inaugurated in the month of December last year. And today we are conducting the first academic program under the aegis of this academy. As it is the first program, we thought we'll begin with the understanding of the basic concepts of lasers in dermatology and its application in routine practice. And hence the topic for today's webinar is basics of laser. Now I take the privilege to introduce to you and invite all our esteemed speakers for today's webinar. Today we have with us three eminent personalities of national and international repute. Firstly, Dr. Professor Arun Inamdar sir, a very well-known figure in Indian as well as global dermatology fraternity. Sir is the senior professor in our department, and sir is also serving as the pro vice chancellor of our university. Sir, as I said, is the director of this academy, BDLA, and I'm very proud and happy to say that sir has always been a constant source of inspiration and a guiding light for all of us in our department. Welcome to you, sir. Next, we have with us Dr. B.S. Chandrasekhar, sir, another well-known personality and one of the senior dermatologists in Bangalore. Sir is the head and director of CUTIS, Academy of Cutaneous Sciences, Bangalore. And we are very proud and privileged to have him associated with our BDLA as mentor as well as a professor of practice. Welcome to you, sir. And last but definitely not the least, Dr. Swapnil Shah sir, a very prominent and globally acclaimed personality in the field of lasers and dermatosurgery. Sir is currently professor and head of dermatology at Ashwini Rural Medical College Hospital, Solapur. And we are also very privileged to have him as the convener of our academy. Very warm welcome to you, sir. Now, without further delay, I'd like to request our first speaker, Dr. Arun Inamdar sir, to begin his lecture on the history of lasers. Over to you, sir.
Thank you. Let me share the things. Well, good evening to all. Yes, this is the first academic program from the BDLA, that is BLDE DECA Laser Academy. Well, this academy is going to have year-long programs for all the aspiring dermatologists, practicing dermatologists about the laser and aesthetics. We thought, as rightly told by our professor, Dr. Keshavamurthy, that knowing the basics is an important step towards understanding the nuances of the lasers, which we are going to learn. And all of you must be really wondering why Dr. Inamdar, who is a very ardent follower of clinical dermatology, is looking at lasers. Well, as the time changes and the requirement, yes, we have to learn. For a learner, the best thing is to learn first the history of the things. So I thought I would do some justice if I can go through the history of lasers and then try to understand with all of you about the lasers basics, whether it is the physics of the laser or the other parameters which you are going to learn from the learned colleagues of mine, Dr. Swapnil Shah and Chandrasekhar. So let me begin with the history of lasers. Well, those who forget the history are doomed to repeat it. Never ever forget the history. Yes. We know, I'm just putting across the slide here, the laser inventors, starting from Theodore Maiman to Swallow. And what is important is the person whom I'm showing you in a different color, the Einstein. And the other side is the first laser and its component, which was the photo taken by the man himself who got it, Theodore Maiman, in his Vancouver apartment. So now let's go through the history now. It's Max Planck was the first person who we regard him as a father of laser technology and the person who invented the quanta. The laser would not have been possible without an understanding that light is a form of electromagnetic radiation. Max Planck received the Nobel Prize in Physics in 1918 for his discovery of elementary energy quanta. Planck deduced the relationship between the energy and the frequency of radiation, essentially saying that energy could be emitted or absorbed only in discrete chunks, which he called as quanta, and the development of quantum physics and quantum biology took the wings from this theory of quanta. Well, all of us know how important in history of science the Einstein. In 1905, Einstein released his paper on the photoelectric effect, which proposed that light also delivers its energy in chunks. In this case, discrete quantum particles, he called them as photons. In 1917, Einstein proposed the process that makes lasers possible, called it as stimulated emission. He theorized that besides absorbing and emitting light spontaneously, electrons could be stimulated to emit light of a particular wavelength. And before laser, there was a terminology called as maser. So in April 26, 1951, Charles Hard Towens of Columbia University in New York conceives his maser. What is maser? Microwave amplification by stimulated emission of radiation, an idea while sitting on a park bench in Washington. In 1954, Towens demonstrated that the first maser at Columbia University, that was the ammonia maser. The first device based on Einstein's predictions obtains the first amplification and generation of electromagnetic waves by stimulated emission. The maser radiates at a wavelength of a little more than 1 centimeter, and it could generate approximately 10 nanowatts of the power. And it was the Nikolai Basov who found out a pumping method in 1955 at Physical Institute in Moscow. Nikolai Basov and his colleague Alexander M. Porkhorov attempt to design and build oscillators. They propose a method for the production of a negative absorption that was called pumping method. If you see the components of laser, pumping source and pumping methods are very essential components. The credit goes to Nikolai Basov. And Gordon Glaudes is an important person who, in fact, he is the first to use the acronym laser. And he has a famous notebook, which I'll be showing you. In September 14, 1957, Towens sketches an early optical maser in his lab notebook. November 13, 1957, Columbia University graduate student Gordon Gould jots his ideas for building a laser in his notebook and has it notarized at a candy store in Bronx. It is considered the first use of acronym laser. This is the famous notebook of Gordon Gould, in which he coined the acronym laser and described the essential elements for constructing a laser. This notebook was the focus of a 30-year court battle for the patent rights to the laser. Notable is the notary stamp in the upper left corner of the page dated November 13, 1957. This date stamp established Gould's priority as the first to conceive many of the technology described in his book. Then there was a patent dispute of the laser invention. Gould leaves the Columbia University a few months later to join a private research company called TRG, that is Technical Research Group. April 1959, Gould and TRG apply for a laser-related patents stemming from Gould's idea. But in March 22, 1960, Towens and Savlo under the Bell Labs are granted US patent number so-and-so for the optical measure, now called laser. And we have to know the person who invented or did the first laser, which is none other than Theodore H. Maiman. May 16, 1960, Theodore H. Maiman, a physicist at Hughes Research Laboratory in Malibu, California, construct the first laser using a cylinder of synthetic ruby, which was measuring just 1 centimeter in diameter and 2 centimeters length, with the ends silver coated to make them reflective and able to serve as a Fabry-Perot resonator. Maiman uses photographic flash lamps as the laser pump source. Well, in 1961 and later years, even the lasers began appearing on the commercial market. October 1961, American optical company Ellis Nidger reports the first operation of a neodymium glass laser. December 1961, the first medical treatment using a laser on human patient was performed by Charles J. Campbell of the Institute of Ophthalmology. So to say, it was the ophthalmologist first used the laser, and an American optical ruby laser was used to destroy a retinal tumor. And Maser got the Nobel Prize also. In 1964, Towens, Basow, and Prokhorov were awarded the Nobel Prize in Physics for their fundamental work in the field of quantum electronics, which has led to the construction of oscillators and amplifiers based on the Maser laser principle. We must be proud about our fellow Indian, Kumar Patil, who was the person who invented the carbon dioxide laser. In 1964, the carbon dioxide laser is invented by Kumar Patil at Bell's lab with a patent number. In fact, he is from a place near Pune, that is Baramati. The most powerful continuously operating laser of its time was his invention. It is now used worldwide as a cutting tool in surgery and industry. But they are also popular for use in skin resurfacing, dermabrasion, and for treating wrinkles, scars, and other skin conditions. Application for the carbon dioxide laser continues to be developed. Yes, we cannot forget the father of laser medicine. We heard father of laser technology, but Leon Goldman was the father of laser medicine. In 1963, Leon Goldman, also known as the father of laser in medicine, was the first to use the laser in dermatology. Goldman reported the effects of Maiman's laser in selective destruction of cutaneous pigmentous structures like black hairs. He also described the potential use of ruby laser and the more innovative Q-switched devices in tattoo removal and the possible treatment of other pigmented lesions such as nevi and melanomas. Goldman investigated the use of argon laser in the treatment of various vascular malformation and also use of carbon dioxide laser for the photo excision of the skin lesions. Well, Goldman was a visionary. He was known for his quote. The first one is, if you don't need the laser, don't use it. Very interesting. But the next line also says lasers have unlimited potential. It is the person who can modulate, and use it for the best potential, best use. So these words has to be remembered forever whenever you start using lasers, I believe. His words and visions are as correct today as they were then also. And well, it is Rox Anderson and Paris who gave the theory of selective photothermolysis. I know Dr. Swapnil Shah and Dr. Chandrasekhar will deal with this simply because they extended the horizon of using lasers to innumerable conditions. The Anderson and Paris also published a theoretical and clinical construct in 1981. In this construct, they identified a chromophore, the concept of chromophore and the wavelength used and selected pulse width. All those things were the boon from the Rox Anderson. And if you just go back, whatever I talked, history of laser, yes, 1916, concept of stimulated emission, Albert Einstein, 1960 Ruby laser, 1964 CO2 laser. So the golden period of laser was in 60s, I believe. Well, afterwards also, dye laser in 1967, 1970 excimer laser, and so on and so forth. We continue to learn and understand. To conclude, yes, history is a cyclic poem written by time upon the memories of man. We are not makers of history. We are made by history. Whatever we are trying to use lasers and make history, well, we have learned from the history, applying and learning. Maybe we'll also leave some history so that the next generation will talk about that. A generation which ignores history has no past and no future. Well, I should say thank you to all, simply because I have to remember Albert Einstein again. He says, I have no special talents. I'm only passionately curious. Well, all of you should be curious so that learning becomes a fun and learning becomes evidence-based, learning becomes challenging. Thank you very much for the time given, and well, next speaker will take care.
Thank you very much, sir. Thank you very much for a very enlightening talk and introduction to the history of lasers. Now I request our next speaker, Dr. B.S. Chandrasekhar, sir, to give his lecture on basics of laser physics. Over to you, sir.
Thank you, Keshav, and thank you, sir. I'm sharing my screen now. Is the screen visible?
No.
Keshav, is the screen visible? Not it?
Yes, sir.
Is it visible now?
No, sir.
No,
sir.
just
now.
Yes.
ಇದು ಮಾಡಿ
full screen, sir.
full screen ಮಾಡಿ.
Fine. Good evening to each and everyone, and I'm here to speak about basics of laser physics. Of course, it's not a rocket science to understand laser, but still it is a little bit more complicated, and you require possibly more readings and more listening to understand the laser physics. Why laser dermatology is so curious today, so well established today, so interesting today, because it is innovative. Every now and then there are innovations in laser dermatology. There are technical refinements every year, and the new devices are coming into the dermatology therapy area every in and out. But it's also hyped up too much. With respect to the fake news, we hear on the outcome of laser therapies. Then there is too much of glamour and glitter around the laser. Probably sometimes it may not be possible for a common man to understand and to come for a laser therapy. There are many claims, but only few proof, because each and every skin differs in its response to a laser therapy. Personal experience probably should be put across. Many a times it doesn't happen. So there's too much of cosmetology attached to the laser dermatology. And also there is lots of disinformation on lasers. So at this particular juncture, it's marred by so many factors with respect to laser dermatology. We know that this is electromagnetic spectrum. We know that the universe is made up of two things. One is a matter, one is a light. Light is an energy. So we have the entire spectrum of electromagnetic in which we are interested. You can see here, it starts from probably the ultraviolet radiations, then go to visible light, then go to infrared rays. The most important spectrum in which we are interested as dermatologists or laser physicians is Somewhere it starts in ultraviolet rays and go up to the far infrared radiations. And the lasers most of the time fits from here to here. If you ask me, what are the wavelengths at which laser can be produced? It can produce from 100 nanometers to a 3 millimeter wavelength range. 100 nanometer to 3 millimeter wavelength range, you can produce a laser. But the dermatology lasers, which are pigment specific, target specific, are produced from probably a 308 to the 10,800, 308 being an excimer laser, 10,600 being ex CO2 laser. That is the spectrum in which we talk about lasers in dermatology. These are the electromagnetic radiation in which, as I already told you, it starts as a cosmic rays, then comes the X-rays, then comes the ultraviolet rays, in which we know that UVA, UVB, UVC. I think we know how the UVC is getting probably contributing lot of skin cancers in fair color skin. We have phototherapy units in ultraviolet for the vitiligo and psoriasis. Then it comes a lot of laser like vascular laser, then comes a hair removal and pigment laser, then comes the CO2 laser at 10,600 nanometers. I think this is a simplified version how the laser system works. So you have an optical cavity. This is an optical cavity. So you have principally an energy pumping system. Then you have inside it, there is a rod or a gas, depending on the lasing medium in which it is kept. Then there are two mirrors here. One is completely reflective. This is a partially transmitting mirror. And this is how the laser system works. There's a laser medium. I'm pumping the energy from out. Either it's an optical energy or an electrical energy. Then I have two mirrors inside the resonator or optical cavity. One 100% reflection and another one partially remittent. And the laser beam comes out, it converges on a lens and comes and probably comes out of the laser device and sits on the skin or focused on the skin. So the common components of all lasers, the active medium can be solid like crystals like Nd:YAG or ruby. Liquid can be a dye laser, pulse dye laser. Gases like CO2 or helium, UV CO2 laser. You can also use semiconductors like diode. We call diode laser hair removal lasers. Then probably even it works on fat. And so many wavelengths are coming out of diodes. Then the excitation mechanism of this can be an optical, it can be an electrical, even it can be a chemical. What is the basic principle in which the laser works or laser gets started or laser gets produced? We all of us know, as I already told you, universe is made up of matter and light. In the matter, the principal basic component of matter is an atom, which has got both nucleus in which you have protons and neutrons, and you have orbits around it in which the electrons are there. When I put energy on this, there will be, these are all stable electrons revolving around this particular nucleus. When I put energy, the electrons get disturbed, they start deviating, they start going from lower orbit to higher orbit. This is the orbit in which the electron is resting. It is going to the higher orbit because of the external energy. When it goes to the higher orbit, it's highly unstable. It cannot stay in the higher orbit. It has to come down. While coming down, it has to lose some energy. Then only it comes down. Here, it is falling down and it is losing energy in the form of a photon. So this is called spontaneous emission. Electron from a stable orbit moves to a higher orbit with instability. When it is moving down, it has to shed a part of energy. That energy is called photon. See, microscopically, the light is particles. Macroscopically, it is in waves. So this is what the fundamental particle of light is, the photon. Similarly, when this particular photon, electron, which is excited, is hit by another photon. See, it's an excited electron. It is already has a capacity to produce one photon. but it also gets hit by another photon. Thereby, it produces two photons. This is called stimulated emission of energy. Spontaneous emission, stimulated emission. The whole laser concept works on stimulated light, okay, not on a spontaneous emission. So another photon hitting an excited electron produces two photons, which comes as a beam out. You try to understand this particular diagram. It's very important. This is the ground state in which the electron is sitting quietly. I've introduced the energy. It has gone to the excited state. It has to fall down spontaneously, giving a spontaneous emission. In between, we have a state called metastable state. You need to understand this concept very nicely. A spontaneous emission electron can fall from excited state to the base state. But to produce a laser, you have some property in a particular medium to have a state called metastable state. What is this? The excited electron comes and sits in between ground state and excited state. It is called metastable state. Here, the spontaneous emissions automatically gets converted to stimulated emission. How does it happen? This happens like this. An excited state electron falls down to a metastable state, and I'm constantly pumping energy, constantly producing photons. These photons are coming and hitting the electron, which is already excited, to produce a stimulated emission. What is the difference between a stimulated spontaneous emission and a stimulated emission laser photon? This is, see, these are all quiet electrons sitting. After the pumping, this is how the photons get emitted. See the photons in different directions. Those who are falling to the ground state or spontaneous emissions. But since I'm constantly bombarding say laser medium with the energy, there is stimulation of energy, stimulated emission of radiation. The excited electron is getting hit and producing two photons, thereby, and this energy is getting reflected by both the mirrors at the end, and there's an exponential release of photons. So if you ask me what is the extent of release of photons, probably in a high output laser, it can go up to the 10 to the power of 20. That means you cannot count it. So it's called exponential energy. So some of these, majority of these excited photons, they align themselves in space and time and becomes as a laser beam. Remember two things. A spontaneous emission photon cannot align itself. Only the stimulated photon gets aligned itself in space and time, producing a laser beam. We know that there is a rear mirror which is 100% reflective and the front mirror which is partially transmissible. Once the amount of energy in this optical cavity reaches one threshold, then the laser beam comes out here. So this is all a mechanism in which the laser is built. To further it understand, spontaneous emission is just decaying by itself, but stimulated emission goes 2 becomes 4, 4 becomes 8, 8 becomes 16, 16 becomes 32. Like that exponentially it goes and comes as a single wave. If you observe this, it is a monochromatic, single color, and it is aligned in space and time and coming out as a laser beam. So as I told you, macroscopically we see it as a wave, microscopically we will see it as a particle. So once the laser is produced, once the beam is produced in the optical cavity, it has to come out of the laser machine. For that, we use a handpiece. There are two types. One is a fiber, one is an articulated arm. The laser gets produced and emitted laser can pass through this. There are some lenses attached in the corners. It gets reflected, ultimately comes out with a probe. So this is how the laser beam gets produced, comes out of the machine and comes on the target. So there are two types. One is a fiber, one is an articulated, which normally we use it in dermatology. What are the properties of laser? You need to understand. Laser light has got a specific property because it has to produce the highest energy to destroy the tissue or to stimulate the tissue, whatever with the laser principles on different dermatological conditions. It is a monochromatic. Whereas a non-laser light, like what is on your head, seeing it is a non-laser. That's a flashlight. It's a polychromatic. This laser beam is coherent. That is, it is spatially arranged. The particle is arranged as the shape is in space, in time. Whereas this is an incoherent light. It's a collimated because they are running parallel to each other. It comes in a collimation. There is no divergence. There is always a collimated beam which comes out, whereas the normal light is a divergent and is a high intensity and this is a low intensity. If you want to put the laser in a layman's word, we are giving a low output into the laser cavity and we are producing a high output. It is as simple as that, but there are complications. There are certain areas where you need to understand. This is an example, the difference between an incandescent source like the light or LED light, what you see on your head or in your front. This is an intense light source where this is an IPL. You know, there is one side IPL, which is a broad spectrum light. Another side, you have a laser, which is a monospectrum light, a monochromatic light. This is the IPL. See, this is an intense light. So the IPL, you need to understand probably how does it differ from a laser? As I told you, it's a monochromatic high beam. IPL, how do you produce an IPL? IPL has no laser cavity. It's a flash lamp. What happens in IPL? We know that it produces a visible spectrum. So we know that the visible spectrum, I mean, this electromagnetic spectrum starts from 1 nanometer, it goes up to infinity. And we know that there are ultraviolet rays coming. In the beginning, after cosmic X-ray, you have ultraviolet radiations, C, B, A, then you have the visible light, then you go for a near infrared and far infrared. When I produce an IPL, I need to shut off the light up to at least 500 nanometer. So I have filters, I put a filter, I'll shut off. Then over 1000 nanometer, because it's a light, it has to travel. Over 1000 nanometers, I want to cut off. So what happens? If you probably go and understand a little bit about optical density, the flash lamp is surrounded by water. Anything which is above 1000 nanometers get absorbed by the water. So you don't get the wavelength of above 1000 nanometers in IPL. So I have a filter to filter up to 400 or 500 nanometer. Then I have a water surrounding my IPL flash lamp, which absorbs the energy above 1000 nanometers. So I am left with only about from 500 to 1000 nanometers. Along with that, we have some filters where you can put that filter. For example, if I have a 650 filter, I put a filter, I will filter the rays up to 650, but above 650 to 1000, the energy comes up. Like that, IPL has got many filters for many dermatology indications. I think this you should understand about IPL machine. When it comes to absorption curve, because entire dermatology laser, of course, it got revolutionized with selective photothermolysis and fractional photothermolysis. According to that principle, there are targets, principal chromophores in the skin, in which the laser get absorbed and brings the biological effects. Like that, if you go, you see there are two curves here, very important curves, which you should always remember. One is the hemoglobin curve, which starts from 400, goes up to beyond 1400. You also have a melanin curve, absorption curve, which starts here and goes up to that. That means any laser of any wavelength you are using on an Indian skin, pigmented skin, there is always a chance for absorption of melanin, which is not as hemoglobin. Hemoglobin shows peaks and comes down, melanin gradually reduces. So anything which you are hitting from almost 400 to almost about 1200, you always have a chance to produce a PAH. That's where most of the dermatology lasers sit and produces PAH. So this is important. And you have a specific absorption spectrum. To give an example, to take an example of a 510 KTP, it is around the highest absorption is a 585 for yellow, that is a vascular laser. KTP laser also vascular because it's a short wavelength, it doesn't go deep. Then you have the alexandrite at 755. Then you have water as a coefficient where you have erbium YAG as well as you have CO2 laser. And NDYAG is at 1064. This is, you should be able to understand this spectrum. Then only you will be able to understand what is the type of laser we produce and what are the biological effects we produce. This is the difference between the laser and the IPL. You can see IPL has got a broad spectrum. It starts around 500, goes up to 1000. I told you why 500 and why it cannot go above 1000. What happens when a laser beam hits the skin? There's a surface reflection, there's a re-emission from some of the particles, and there is a transmission. Reflection, remission from few epidermal structures like DNA, keratinocytes, then the dermal collagen, and there's an absorption by chromophore. Either it's a hemoglobin or a melanin, or water is a chromophore. So this is how especially the melanin with respect to hair removal and pigment relations. So these are the chromophores. It also gets transmitted. So there is a lot of energy which goes in waste when you put laser beam. So all laser machines are based on the calculations of reflection, re-emission, then the absorption spectrum comes, in which we are interested today. The absorption of a laser beam, we are interested today in only this particular principle. So when a process of dermatology importance, this is the skin, this is the target, you can think. So by producing, by giving a laser beam to achieve a temperature, to produce different biological actions, when the phototherapy or LLLT, it's only athermal cellular photo bioactivation. You mean you give LLLT for, something like hair growth. Then you have a protein degradation, protein denaturation. When you want to remodel the skin, probably you need to work on the collagen. When it happens at 55 and 40 or up to 60 degrees centigrade is a coagulation. And you go beyond that, like CO2 laser RBM, you're putting carbonization and vaporization of the entire tissue. So these are this is the target tissue. This is what the temperature you need to achieve for a specific biological effect. And this biological effect is produced by different types of lasers, which we are going to tell you further.
Hello.
So, these are the interaction photobiomodulation. That is a gene expression. The best example would be alopecia areata treatment with eczema. Photothermal light energy get transformed to heat, collagen remodulation. Then you have photomechanical, photoacoustic like Q-switch lasers, where you need a highest energy to blast the pigment. It creates a shock wave. Then you have a photochemical like pulse dye therapy using ALA. Then you have photoablation like removal of tissue, tags, or tumors by CO2 laser. That's a photoablation. So these are the different spectrum of dermatology lasers. Most of us know about eczema. We know about KTP at 532, which is very, very dangerous. One should be very careful in Indian skin because its penetration depth is short. It is have the highest melanin absorption activity. So you can induce PIH. You need to be very careful. Then you have a vascular laser at 585 to 600. Ruby, of course, we don't use much for the skin. Alexandrite, of course, for a sensitive skin, type 1 and type 2 is a wonderful laser. It comes as long pulse as well as Q-switch. Diode comes here. The highest penetration depth, longer the wavelength, deeper the penetration, shorter the wavelength, less is the penetration depth. The best example is this, eczema and argan. And the longest penetration for hair removal, we choose 1064. This goes up to here. Then over that, because we know that epidermal has got a lot of water and there's absorption of water, laser by water. That's why the erbium glass is here. Thulium laser is here, erbium YAG is here, 2 microns, and CO2 laser at 20 microns, because over this, most of the laser beam get absorbed by water, which is abundantly present in the skin. So classification of laser is based on the medium. You have a gas laser like CO2. You have a liquid laser, rhodamine dye, PDM. Then you have a solid state laser, alexandrite, erbium YAG, and all those things, and semiconductor diode laser. And on many devices, when you targeting the tissues, we have a different classification. One is a vascular laser. Then you have classification of pigment laser, which works on melanin and tattoos, and hair removal lasers, which are work on hair. And of course, there are tissue-specific lasers, which are getting evolved now in the form of lasers for fat, lasers for collagen. It's all happening. That's what I told you in the beginning of my talk. It's an innovative field. Every now and then, the innovation occurs in laser dermatology. What is the laser language? We came to know what is the laser, how it is produced, and how the laser beam comes out, how is it targeted to the skin, and what are the different wavelengths at which we produce a dermatology laser. Now we have a laser language. When you're talking to people, you have a language of lasers. What does it contain? It contains fluence, that is joules per unit area. Simply, it is energy into area. Joules per area, that's how I put it as EA. In power, you have joules per second, energy density and exposure time. Here you have energy with respect to time. Then irradiance, which are very, very important for us. It takes into consideration the energy, the area, then the time. So it's called EAT. You have energy, area, and time. This is the irradiance. This is exactly what we look at in the biological effects of a dermatology lasers. Then you have a term called hertz, in which how many number of times you are producing your per second you are putting the laser beam. Then we know about chromophore. I already told you. Thermal relaxation time. This is the time needed for a heated tissue to cool down to half its virginal temperature. We know that. Take an example of 1064 laser. We know that there is a melanin absorption. So now we are putting the laser beam to destroy the hair follicle. Your skin epidermis also has melanin. Hair follicle also has melanin. So I should consider what is the relaxation time. That means when my laser enters into the hair follicle, it should not get dissipated to destroy the epidermis. Within that time, it should cool down. Hair follicle should absorb the energy and it should cool down before it gets dissipated. That is called TRT, thermal relaxation time. It's very, very important factor. Probably Dr. Swapnil will be going to speak more on that. Then you have a thermal damage time. Again, an example of hair follicle. We know that hair follicle has got the stem cells at the bulb region, and that's the stem cell, the dermal papilla cells. You need to destroy both. When I'm giving a laser beam to the hair follicle, I expect dissemination of energy from follicle to the dermal bulb region to destroy the stem cell population. That is called thermal damage time or extended thermal time. Then you have a cooling, because you know that melanin and hemoglobin are there to absorb every beam of all the wavelengths we used in dermatology. You need to cool the tissue to protect the epidermis. Then you have a pulse duration. And what is the duration? Dwelling time of the laser. For example, it can be a second, it can be a millisecond, it can be a nanosecond. Then you have a spot size. What is the area in which your laser beam is going? That's the laser diameter on the skin surface. This is the language of lasers. And there are parameters. Pulse duration can be seconds. The dwelling time can be seconds. It can be milliseconds. It can be microseconds. It can be nanoseconds. You know, seconds probably when you are doing an ablative work. Milliseconds, you are doing probably a pulse, ultra pulse laser or those kind of lasers. In microseconds, probably we work on the laser toning. Then nanoseconds to target the pigment in the form of Q switch laser. The frequency, that's a pulse per second, you call it as hertz. Wavelength always in nanometers, and spot size will be told in millimeter. And this is the spot size. The one rule of a laser, probably the smaller the spot size, less deeper the penetration. Larger the spot size is more deeper the penetration. This is laser beam types. What are the types of laser beam which is coming out? You can produce one. You can produce a continuous laser. Then you can have a millisecond laser. Then you can, this is a millisecond laser, which is ultra pulse or those kind of lasers. Then you have again microsecond laser. Then you have a nanosecond laser. See the energy levels here. Continuous level energy gets more when it goes for a shutting. It goes for millisecond laser, it goes more. Then it goes more severe, more energetic when it comes to a nanosecond. In microsecond, it is somewhere between this and this. To understand it better, this is what the depiction. Continuous laser, we call it as seconds. In quasi-continuous laser, which is a continuous beam but shut off with a shutter, and there's a shut off, immediately it goes up, again shut off, goes up, shut off, goes up, and this is how you produce higher energies. This is the principle of the ultra pulse CO2 laser. Then you have the pulsed laser for millisecond, which typically a hair removal laser, and nanoseconds, which are typically Q switch laser. This is the different types of laser beams: continuous wave, quasi-continuous wave, and pulsed wave. This is the laser beam types and the characteristic. What is the continuous wave laser? continuous beam of light, little or no variation in power output. It's a constant power. Then you have a non-selective tissue injuries, right? Ablation work. There's a no, because the chromophore is not, as the heat spreads from, water is the chromophore in most of the time and heat spreads. And the best example is CO2 laser. Quasi-continuous mode, you have ultra pulse, super pulse lasers, continuous wavelength lasers that are mechanically shuttered to deliver pulses light or short as 20 milliseconds. The laser comes for 20 milliseconds, shuts off, again comes for 20 milliseconds, that is quasi-continuous. Produces individual pulses of light energy within the pulse, is not constant, but rather builds, peaks, and tapers. It is something like you're washing your car, and you want to give more pressure, you're going to squeeze the pipe. When you squeeze the pipe, the pressure comes and it hits the glass. Suppose you are washing the front glass of the car, your water is not reaching the back glass, then what do you do? You're going to press it. Then the force comes out and you can wash. So it's a simple explanation. May not be suitable directly, but this is how you should understand the pulse laser. This is the super pulse and ultra pulse lasers. And lower risk of thermal injury because it's not a continuous energy which is coming off. It is getting shut off, allowing the skin to cool, thereby the thermal injury is less. The best example is a KTP laser here. Then you have pulse lasers. I think this is the long pulse laser, Q switch lasers, all these belong to a pulse lasers. Based on pulse duration of lasers, when you talk about laser language, when you are talking about continuous lasers like CO2, we talk about power, time, and spot size. We know the power, the time of dwelling, and spot size. When you are using a pulse laser like Q switch laser or a hair removal lasers or a vascular lasers, we talk about energy per pulse duration, spot size, fluence. I think these 5 or 6 parameters Dr. Swapnil is going to tell you in detail. So this is the pulse profile. When the pulse is coming, we know the beam, how it's coming. How does it exactly sit on the skin? There are three types of pulse profile. One is a Gaussian beam, one is a donut, and this is the ideal top hat beam. In a Gaussian, you see the energy is concentrated in the center of the beam. Then it slowly wears off. So when you are hitting, maximum effect occurs on this particular spot. In a donut, there are one cold spot. But most of the time, we are interested, these are all continuous lasers like CO2 works on this principle. Top hat beam, especially it works on the vascular lasers and pigment lasers. So this is how the energy is very, very uniform. Going further, you can understand it better. The Gaussian beam, you see the maximum spot is here. Surrounding area, there is the energy levels are different. So if you are not careful, you're hitting one area very strong and you're not producing any effect in the neighboring area. Whereas in top hat beam, almost all the energy becomes uniform. So you have handpiece. There are two types of handpieces in lasers. One is collimated. There's no change. Even if you take the laser beam out like that also, the beam comes in the same way. And the other one is a zoom. If you want to target one particular target with the highest energy, you can use a zoom piece. As you go up, it becomes narrower and narrower. Okay. Thermal relaxation time, as I told you already, there is every target like a melanin, like a high oxyhemoglobin. They have every tissue. For example, hair follicle, the melanocyte, the tattoo particle. They have a specific thermal relaxation time where they get heated up and they don't allow the energy to dissipate. That is called TRT. This is the basic of TRT. Very easily can be understood. This is the target tissue. I am putting the laser pulse duration is optimal. I am destroying this. In case if pulse duration is too long, my energy is going to target, but it also dissipates the surrounding area, producing a lateral damage. This should not happen. These are the different particles. We have tattoo particles. What is the TRT of tattoo is 10 nanosecond depending on the size. Then you have melanozyme, you have 250 nanosecond. That's why these two things are worked on Q switch lasers, where you have a nanosecond pulse width. Then you have the Port-Weinstein vessels, which are 300 to 100 microns, 1 to 10 millisecond is the TRT. So we work on 0.4 to 20 millisecond. On the hair follicle, the size of the hair follicle is large. So we work on 100 millisecond from always average from short pulse to long pulse. It's very critical. Of course, this probably you will learn later. And because, as I said, when I'm putting my laser beam, I need to protect the epidermis. I've got skin cooling devices, spray cooling, cold liquid, solid contact cooling, and cold air, cold gels. You can put ice packs, cold gels, or the laser can come with a sapphire window, which on contact cools the skin. You can also have a zimmer to cool the tissue. These are the different types of skin cooling, which are very important in laser dermatology. Pre-cooling, parallel cooling, and post-cooling. We can cool before with ice packs. Parallel cooling can be done with a dynamic cooling, and post-cooling with ice packs or pads. So these are the optimal results for pi parameters. This is the what Dr. Swapnil probably is going to talk about. And we have to understand one Q-switch laser. We know that there are long pulse lasers, there are Q-switch lasers. Q-switch lasers is simply, you will have to understand that in Q-switch laser, there are mirrors on the rear mirror and front mirror. There is no partial transmission here. Both are reflective, 100% reflective. We know that in Q-switch laser, we are trying to destroy a minute targets like melanin, like a tattoo particle. So it's almost like into atom bomb explosion. So you need to have highest energy, which comes out and destroys. So you need to store the energy, build up the energy in the laser cavity, suddenly release that energy so that it produces very high impact on the target. So that is the principle of Q switch. The energy gets built up here. There is a switch. When the switch gets on, maybe nanoseconds or a picoseconds, the mirror opens up and the gush of light comes out and hits the target. This is the basic principle of Q switch. Q stands for a quality factor, but that's again a very deep physics. Probably once you start reading about laser physics, you will understand. But at this particular stage, you understand only this. Q switch lasers or highest energy producing lasers. So they have a cavity. We need to store the energy. We need to pump up the energy, build up the energy. We need to release the energy at one shot. That's why when the switch is on, the energy gets released and hits the target. And similarly, you can also modify the frequency. For example, 1064, if you want to reduce it to 532, you can have a crystal in between, whereby the 1064 nanometer wave comes through this crystal, gets converted to 532 nanometer. It's called double frequency half length. Similarly, you can also have some polymers which are impregnated. For example, if you go for a squeeze switch laser, you have one side 532, 1064, 595, then you have 660. There are a lot of parameters, the wavelengths which are produced by using a polymer filters. So when you're buying a Q-switch laser, you can always ask about these different polymers, different wavelengths which are produced. Of course, you don't expect the energy to be as high as the original 585 nanometer for a vascular laser, and for example, 1064, 532 for a freckle. So theory of selective for photothermolysis, we know that I already told you over my presentation. You have a target. It's developed by Parrish. That's a revolution in laser dermatology. It states that laser light can be absorbed by a selected target chromophore with minimum damage to the surrounding tissue. So we know that chromophores on which the various nanometer wavelength lasers are working. That is the principle. So you have to consider wavelength for this principle, pulse duration, and energy density. This is how you work on selective photothermolysis. To understand it better, I have a target. There's a thermal diffusion, short pulse duration of the target, long pulse duration, it hits the target and goes away. So this is, suppose you take an example of a melanin here. I need to target only melanin, not the surrounding tissue. This will be explained a little bit later. And this is extended selective photothermolysis. As I told you in the initial example, to give an example, I think it's better you understand by examples. Hair follicle, I'm putting my energy to the dermal papilla. I want the stem cells to get destroyed. The target tissue is away. It is in the bulb. So this is extended theory of photothermolysis. This heat has to dissipate to this area to destroy the stem cells. This is called extended theory of selective photothermolysis. We also have a fractional photothermolysis. We know that instead of putting energy into a block, we fractionate it like this. This is a fractionated column. This is a normal skin. And when it is healing, this particular normal tissue contributes to the healing process. Previously, when we had a continuous lasers like erbium YAG, which is continuous laser, not a fractionated one. The healing time used to take about nearly 3 to 4 weeks. The fractionated laser, where you're targeting the tissue with fractions of energy, and the healing time comes down and the complications are less. This is well depicted in this particular photograph. This is fractionation of laser beam. To depict it further, we have a non-ablative laser resurfacing where there is no fractionation. The energy gets heated up. There is no ablation. Ablative laser resurfacing, you can see the ablation here, and the rest of the heat is producing collagen remodulation. You have a non-ablative fractional photothermolysis where there is no ablation, but still there is a modulation. There is an ablative fractional photothermolysis by a CO2 fractional laser. This is fractionated erbium glass. Then fractionated, probably it can be a erbium YAG or a CO2. This is erbium glass. This is how you are going to learn different types of laser. So you should know the rules of laser. Rule 1, longer the wavelength, deeper the penetration. Rule 2, larger the spot size, deeper is the penetration of the laser beam. Wavelength, deeper, larger spot size, deeper. Rule 3, smaller the spot size of the laser, lesser is the pain, because number of nerve terminals getting into heated up or less in a smaller spot size when compared to larger spot size. There is a summation of nerve terminals there. So aiming beam, because you know that the lasers are in both visible range and invisible range. In a visible range, probably starts from 400 to 700. So they have a specific color. For example, a KTP has got a green color. Vascular laser got a yellow color. When putting a laser beam, you can actually see them with a protective glass. But beyond that, it becomes invisible. You don't know where your laser is hitting. For that, they give a diode as an aiming beam. When you have to aim, you see the red color on the skin, press the foot switch, the laser beam comes out. So this is the importance of aiming beam. Laser hazards, you have eye hazards, skin hazards, and chemical hazards, electrical hazards, and 5. Of course, eye protection, both for the patients and you have a specific numbering of the glasses with respect to a particular laser. You need to use both for you as well as your patient. Complete opaque goggles have to be given. Then you have to identify the eyewear for a particular wavelength. Engineering controls in a laser machine. All laser machines come with interlocks and enclosed beam. Administrative controls, you need to have a standard operating procedures, training, and eye protection. These are the different signs and labels you should put on the laser outside the laser theater. Then clinical images. I just want to take you with some of the clinical images where you can give such a wonderful satisfaction to your patients. You see these papilla scars. It's a CO2 ablation. There's a complete removal of it. Then you have an acne scar with a erbium YAG laser. You can see a wonderful improvement in 4 sessions. This is one of the worst scars you have. We have done a CO2 laser for about 6 sessions. You can see the improvement here. These images I am showing to impress upon you that laser is a fantastic tool for dermatology practice. So cosmetic practice as well as clinical dermatology practice. This is one hard pigmentation. We have combined 1064 Nd:YAG as a pigment laser, fractional laser to remove the excess skin. This is the outcome what you get. This is freckles in 660 nanometer. Then you have an inverse of VOTA with a Nd:YAG laser. Then you have epidermal nevi, congenital melanocytic nevi, sorry. This is how it is, but only a few freckles are remaining. This is how the lasers are done using CO2 laser as an Nd:YAG laser and a pico laser. This is a vascular laser which has produced clearance. The patient is still undergoing the procedure. We have already done 7 sessions. This is a tattoo removal, but the ghost mark sometimes remains. It depends on the technique of tattoo. Then you have the hair removal lasers with a wonderful results. So application of laser on Indian skin, I think the last 2 slides from me, you should understand these are the things you should look for in Indian skin. Anatomical difference, high epidermal melanin content, thicker the compact epidermis. So whatever the parameters you get with your laser device, most of it is done on class 1, class 2, and class 3 skin up to certain extent. But we belong to class 4 and class 5. So we have an anatomical difference. We have a high epidermal melanin content. We know that our compact dermis is thick. So you need to modify the parameters. You cannot go by the parameters what they say. If you go by the parameters what they say, either you don't produce a result or you end up in producing a complication. So longer wavelengths over shorter, what you prefer for Indian skin, longer wavelengths over shorter wavelengths, long pulse duration for LHR, intermediate pulse to long pulse for vascular lasers. Avoid stacking pulses in darker skin because you are going to scar and pigment. Short pulses and ultra short pulses in resurfacing, smaller spot size to avoid collateral damage, minimal fluence to be used. When you are working on this, you work on a pulse width as spot size rather than fluence. You know, the irradiance is different, fluence is different. You see a fluence on the laser mission. You don't see irradiance on the laser mission. The what energy comes out of it is different. What is dwelling on the skin will be different. Probably if you get into the little bit of laser physics, time is very short to explain. You will understand. But remember, the fluence what you are putting is not the same what happens on the skin because irradiance is different, fluence is different. Laser resurfacing, keep total energy deposit under control always. Cooling is a must. Cooling is a must. Cooling is a must. So you should have a basic knowledge of the skin, knowledge of laser devices, knowledge of laser tissue interaction. Laser manuals and laser algorithms and workshops would come to your hand, and you should learn by experienced laser physicians. So experience is very important. You can have a tailor-made settings to your patients. No single patient is, no two patients are identical with respect to their manifestation, with respect to their response, with respect to their side effects. Please remember that. You cannot extrapolate same thing with another patient. You need to learn that particular technique that comes out of experience. And probably, as Sir was telling in the beginning, laser device is wonderful. It is there to stay and it is there to modify our patients' lives. But at the same time, you need to know how to prevent side effects. Thank you. These are my references. Thank you very much.
Thank you very much, sir, for a very exhaustive and a very informative talk. Now I call upon Dr. Swapnil Shah, sir, to deliver his lecture on how to master control over the laser devices for optimal usage of the lasers and patient benefit. Over to you, sir.
Is my screen visible?
Yes, sir.
Yeah, good evening. So I'll be again talking on the same topic of basics of laser and laser tissue interaction. I'll be brief. Most of the talk has been covered by Chandrasekhar sir very well. And I think there is nothing much to speak on it. But before that, this webinar is by Bdla, which is basically a joint collaboration between BLDE University Vijayapura under the guidance of Dr. Inamdar sir and Deca Lasers Italy. With this course, with this association, we are trying to bring out many such informative webinars on lasers. And more than that, the BLDE University is going to start a certified laser fellowship of almost 1 year duration with leading experts in laser surgery from India. And more details can be posted to you sooner or later. And we are starting probably by the June of this year. So interested candidate can contact BLDE University for the fellowships. So coming to the basics of lasers and laser tissue interactions, we know the role is increased dramatically over the past 2 decades, and the fundamental understanding of laser tissue interaction is vital for the proper and appropriate clinical practice of lasers. So what sir has already told you, properties of monochromatic laser lights is monochromatic, coherent, collimated, and intense. But why it is important? A monochromatic light is made up of one single wavelength or a very closely ranged wavelength. And that is especially useful for selective photothermolysis, where a chromophore is going to absorb one single wavelength. And that gives you importance of monochromaticity. The coherent light, it is in phase with each other in time and space. Why it is important that a laser light should be coherent? Because we can focus them at one particular point. All the photons in a wave can be focused on one particular point by using a wavelength. If you have an incoherent light, it is very difficult to focus that entire light which is produced by the laser, by any other source to a one particular point. And that's why coherence is utmost important in lasers. And it is collimated because the phase and amplitude is same, and that's the important characteristic of a laser light, because the laser is going to be produced in the machine and it is going to be delivered on the skin through an articulated arm or the fiber optic delivery. And during this transmission of the laser light, if it is not collimated or if it is divergent, the energy it is going to lose the energy which is being generated in the laser cavity. So to avoid that, the laser is beautiful. It's collimated, and it refers to the parallel nature of the waves, so that they do not lose energy infinitely unless they are focused at one point by a focusing lens. So all three properties produces an intense beam of light. Monochromaticity, the coherence, and the collimation. All these three are important as far as to have a selective photothermolysis that can be focused, and the laser should not lose its energy. So selective photothermolysis, we all know, we all read, always read this. It has been proposed by Anderson and Parrish. And this idea in a simplistic way is to involve hitting the target tissue without overheating the surrounding tissue by restricting the time in which laser energy was applied, thereby minimizing the collateral damage and scarring. So we do not want a laser to damage its surrounding tissues, right? And that's why selective. So selective is discriminant, photo is light, thermo is heat, and lysis is by. So we are discriminatingly targeting the tissue using a light. For selective photothermolysis, correct wavelength for the chromophore, that is a monochromatic light, a correct pulse duration of a laser, exact fluence, correct spot size, and it should be cool enough to prevent the surrounding damage to a non-target tissue. By achieving all this, by selecting a wavelength of appropriate pulse duration, appropriate fluence, and appropriate spot size, and an effective epidermal cooling, we can achieve a selective photothermolysis. So the thermal relaxation time, sir has very nicely explained. The thermal relaxation time is, by definition, is defined as the time taken for the central temperature of the target to decrease by 50%. And TRT is directly proportional to the size of target. If the pulse width is greater than the thermal relaxation time, non-specific thermal damage occurs because of heat diffusion. And this is the TRT, which is sir has also shown. Remember this. We just I want you to concentrate on these two things. The TRT of a melanosome of 1 micrometer size is 1 microsecond, and the blood vessel, it is around 1 millisecond. Just remember these two pulse width, the TRTs of these two molecules, 1 microsecond and 1 millisecond, right? So coming to the laser terminology, we have talked about, sir has talked about it, but I'll talk about an applied aspect. Coming to a wavelength, lasers are monochromatic. They are made up of single wavelength or a very closely packed wavelength, like between, let's say for an excimer, we say it is 308, but it is actually between 306 to 311. So it's a single wavelength or a very narrow range of a wavelength. Monochromatic nature of light is a critical property for application of laser because cutaneous chromophore selectively absorb different wavelengths. Lasers are now available from UV rays to visible light to infrared wavelength. So almost all the lasers are now available. The specific wavelength of the laser light also affects the distance it can penetrate the tissue. Generally, the longer wavelength penetrates deeper and the shorter wavelengths penetrate superficially. Longer wavelength penetrate deeper and generally preferred while treating the dermal structure. The corollary to these two things about the penetration depth, it stands till of near infrared range. As you go in the far infrared range, like an erbium YAG or CO2, the penetration depth is not so great because the chromophore is different. The chromophore is water, and that's why they do not penetrate as deep as the 1064 or our diode 810. The penetration depth of these wavelengths are superficial. That's one. And a laser which defies selective photothermolysis is a continuous wave CO2 laser. A continuous wave CO2 laser do not, the principle of selective photothermolysis do not apply to the continuous wave CO2 laser completely because there is no pulse duration to a CO2 laser. So we are using water as a chromophore and just bulk heating. So that's why what sir has told, even though a CO2 laser in a continuous wave is superficial, it produces less absorption, but it is devastating if it's used incorrectly because it causes a lot of surrounding heating and damage. So another important thing, energy of an individual photon in a monochromatic light is calculated by this formula. E is inversely proportional. The energy of photon is inversely proportional to the wavelength. What does this mean? The longer wavelength requires more proton to deliver a specific amount of energy. So when you treat a hair laser with a alexandrite diode or NdYAG, the same amount of energy if you use, obviously the NdYAG will require a higher amount of fluence than diode than alexandrite, because the melanin absorption is also different for these three wavelengths. However, still the NdYAG is going to be the more painful laser than a diode or an alexandrite. The alexandrite is going to be the least painful laser, because for selective fluence, NdYAG will require more photon, because energy of the photon is inversely proportional to the wavelength. So the longer the wavelength, each photon will carry less energies, and that's why you require more photons. That means more pain. So longer wavelengths generally produces more pain because of this formula. Wavelength is an important concept to understand because it identifies a particular region of electromagnetic spectrum, like excimer or 635 nanometer in a visible radiation, determines the color of the beam. 532 is green light, excimer is slightly blue light, but the infrared is invisible. Determines the light tissue interaction, transmission or absorption by the tissue depending on the chromophore. Dictates the lens color or the lens material used in protective eyewear. So the protective eyewear which we use is determined by your wavelength of the laser which you are using, and relates to the amount of energy carried by the waves, as I shown in the previous slide. So there are different medical lasers which has been explained by Sir to you. Coming to the frequency of a wave. The frequency of a wave refers to a number of wave peaks that pass through a given point every second, expressed in cycle per seconds or hertz. Wavelength and frequency are inversely proportional. That is, shorter the wavelength, higher the frequency of the wave. It is important not to confuse frequency of the wave or radiation with the frequency of the pulse emitted from a laser, which is been pulse repetition frequency or pulse rate, the number of pulses emitted. Here we are not talking about that pulse, like when you use a Q switch laser, we have 1 hertz, 2 hertz, 3 hertz, 10 hertz. That is not what I'm talking about. I'm talking about the frequency of the waves. And this Sir has explained to you what is the frequency doubling. This is classically seen in Q switch when an NdYAG crystal produces 1064 nanometer, and if it is passed through a KTP crystal or lithium triborate crystal, the frequency is doubled. That means the distance between these two peaks are shortened. So the frequency is double. There is a shorter distance between the two, and you get a 532 nanometer KTP laser. Similarly, one can use a third. This is called as second harmonic generation. Similarly, one can use a third harmonic generation. So using a tri-sapphire crystal, you can produce a wavelength of 933 nanometer. And when it is passed through this lithium triborate crystal 2 times, it produces 311 nanometer, which is used in excimer lamps. So without using eximers, without using any gas, with a solid state laser using the third harmonics, you can generate a 311 nanometer, which is seen in a newly introduced excimer lasers. An alternative method, as Sir showed, instead of using a crystal, you can use a dye-impregnated polymer to produce a different wavelength. And this is seen in most of the Q switch laser. You get 2 additional wavelengths, 585 and 620 nanometer, when you buy a standard Q switch laser. However, the output power produced by these dye handpieces can be significantly lower than the fundamental beam size due to a multiple wavelength conversion, which introduces losses. Strictly speaking, these are the divergent beams. These are not the collimated beams, and hence they are truly not lasers produced by 585 and 595. Consequently, the spot size of such handpieces is often smaller to compensate the lower output power. So generally, these come with a fixed spot size of 5 mm. You cannot increase the spot size because there is a significant energy loss. Coming to the concept of chromophore, chromophore is well defined as is a molecule that acts like a catalyst to allow light-induced reaction to occur in an otherwise non-absorbing molecule. So for laser, we have different chromophores in our skin: water, oxygenated hemoglobin, deoxygenated hemoglobin, protein, which is collagen. We have a newer wavelength which selectively can target this collagen. You have melanin, tattoo particles, and DNA. The DNA is used in eximers. The target of excimer laser is a DNA. So this is an absorption curve. So you can see that Sir has explained to you. So melanin has a longer absorption curve. Almost every single wavelength produces. Interestingly, if you see for a vascular laser, 577 is the highest peak of an excimer. For the oxygenated hemoglobin to absorb light. But still we use 595 or 585. Why? Because 577, although it has a maximum absorption for oxyhemoglobin, as I told you, the depth of penetration of a longer wavelength is more. And we know while treating port wine stain, we are actually dealing in papillary or deep dermis. To reach that, we need a longer wavelength. So although the absorption of 595 or 585 is less than 577, we still use that property. So that's how one has to choose a laser. Like initial lasers which has been used for vascular lesions is 577. Gradually it is turned to 585, and now we have 595. So we have still a higher peak, but it also penetrates deep, so we can take that advantage. And this is how this absorption chart should be read. And it's very important because whenever we treat with 595 or 577, the melanin also has a great absorption peak at this time. So it's very difficult to use these lasers in our skin if we don't have an effective cooling, and we have to use a low fluence to prevent a collateral damage to melanin. So this is the penetration depth of various lasers the sir has explained to you. And this is actually the penetration depth of various lasers. And if you see anything between 600 nanometer to 1300 nanometer, all the wavelengths reaches subcutaneous fat, right? So the triple wavelength lasers or the quadruple wavelength laser, what they say that you can target different targets of a hair follicle with a different wavelength, because alexandrite penetrates little superficial. It's not true, because all the wavelength reaches to up to a subcutaneous tissue, and we know hair follicle is in deep dermis. So almost anything from 700 to 1064 can be used for hair removal to all target all the hair matrix and the stem cell effectively. Spot size, sir has explained. A larger spot size is basically better because there is a less scatter. I'll come to that later, what is scatter. But you have a more fluence or more photons available to destroy your target than a smaller spot size. So you should have you should use a large spot size as whenever it's possible. And you should use a collimated handpiece because the spot size remains constant whether you are in contact with the skin or you are slightly away from the skin. So even if you hold a laser like a paintbrush, and if you do it, a collimated collimated handpiece allows you to do that. However, when you are using a zoom handpiece, it is imperative that you should always be in contact with the skin. Power energy. The definition of energy is a capacity to do work. The unit of measurement is joule. Power is the time rate at which energy is emitted by the laser. The unit of measurement is watt. So 1 watt is equal to 1 joule per second. This needs to be remembered because whenever we talk about energies and watt, generally we use watt for ablative lasers and energies for non-ablative. This is a general description, but what is the difference between a watt and a joule needs to be explained. Irradiance, sir has explained. It is a concentration of beam of light and expressed as power applied per unit area. So it is expressed in watt per square centimeter. Power density is determined by the power divided by the surface area of the beam or the spot size. Fluence, this is what actually we use always. Actual amount of energy applied to the unit area of target tissue and dependent on the exposure time. So fluence is power into exposure time divided by the area, centimeter square. So you can increase the fluence by simply increasing the power, or by keeping the power same and increasing the pulse duration, or by decreasing the spot size. So your laser machine should allow you to adjust fluence by all three ways. You should be able to increase the power, or you should be able to increase the pulse duration at a given power, or you can decrease or increase the spot size depending on the indication or the depth of chromophore which you are targeting. So you can increase the fluence by all these three methods. And this is very important when you're using CO2 laser. For example, if you want to increase, if you want to treat deep, you want to go high and you do not want a lateral damage to occur. So you increase your power to 30 watts and deliver it. So your pulse duration is automatically going to be less and you can go deep. As against, if you use a lesser power, lesser wattage and increase the pulse duration, you are going to get laterally and bulk hit the tissue. And that is very effective if you are treating wrinkles or wrinkles or sagging skin in a type 3 or type 2 skin. Pulse duration, amount of time the laser energy is applied. The pulse duration is determined by the TRT of the intended target, and unit of pulse duration is 1 millisecond, microsecond, nanosecond, and picoseconds. So we have all these lasers available. Millisecond lasers, which is basically we use it for laser hair removal. Microsecond laser is a quasi long pulse NDR, which we use for non-ablative treatment. Nanosecond is Q switched, and picoseconds are picosecond laser. Pulse duration should be less than TRT of the target chromophore. And this, sir, has explained nicely what is an advantage of continuous wave. Continuous wave, larger areas can be treated rapidly. Disadvantage, it has a reduced safety profile, especially for beginners, because it is bulk hitting the tissues. A pulse laser delivers beams in pulses, and the pulse width can be in millisecond, microsecond, nanosecond, or picosecond. So this is what sir has explained. And it's very important to see this graph, how the pulse duration matters. So a Q switch laser is available from 0 to 20 nanosecond. At 20 nanosecond pulse width, you achieve around 150 megawatts of peak power. At 5 nanosecond, you achieve around 100. And if you are between 0 to 5, you are achieving 200 nanoseconds of pulse peak power. And that's very important. So just by reducing the pulse width, you can increase your power of the laser system. And the Q switch, this is a graph for Q switch laser, which even with 0 to 5 nanosecond, you achieve around, say, 200 megawatts of energy. And if you go in a picosecond laser, the energy is going to be delivered in gigawatts. And that's why it's very, very effective, right? It's very high energy. So reducing from nanosecond to picosecond, your peak energy goes very high. Beam profile, it's very important to have a top hat beam profile. Every single laser produces a Gaussian beam. This Gaussian beam is converted to a top hat beam by using delicate lenses and spatial optics. So advantage of top hat beam is the energy is going to be distributed at a selected spot. So if you are using, say, 8 mm spot, every 8 mm circle or square will receive the exact amount of energy. The Gaussian beam, you will have energy concentrated in the center, and the periphery will receive a less energy. The problem is center is going to be over-treated, which can result in complications. And the periphery is going to receive a less pulse, which can result in paradoxical stimulation. So a top hat beam profile is the best profile where there is no hot spots. Epidermal cooling is very, very important. Sir has talked about it, and I'll explain why epidermal cooling is important in my next slide. Fractional thermolysis, I will not talk much about it because it warrants a second lecture. Just instead of treating the entire tissue, you fractionate the tissue so that the injury between the skin between the two zones of injury will act as a regenerative store, and it will regenerate the tissue. So coming to the important topic of laser tissue interaction, laser interacts with tissue by absorption, scatter, or by transmission. So transmission, when a laser is fired on a skin, and if there is no chromophore, which you are targeting, the laser is going to transmit it deep into the skin up to subcutaneous tissue. So transmission, this is an unintentional fire. We do not want laser to transmit to the skin. Reflection is important. The amount of light reflected generally when a laser light falls on a skin, 4 to 7% of the light is reflected back from the skin. And the amount of light reflected increases with the increasing angle of incidence, with the least reflection occurring when the laser beam is directed perpendicular to the skin. And that's why we should always hold our handpiece perpendicular to the skin, because we do not want our valuable laser energy to lost or reflected back. The problem in reflection, if somebody is not wearing the protective eyewear, he is going to get eye complications. And you are going to deliver the less energy to the target anyway. So the handpiece has to be perpendicular to avoid this reflection or keep this reflection minimum to 4 to 7%. Dry and scaly skin also increases the reflection. And that's why it is very important to examine your skin if there is a excessive dryness, you should not do lasers on that. You try using moisturizer gels to avoid this dry scaling. And this is classically in an excimer laser when you treat palmoplantar psoriasis. You have a very thick skin on the palmoplantar with the white scales. And if you fire excimer, the excimer is not going to get into the skin. It is going to be reflected from the scales. To avoid that, it's a good idea to use a mineral oil on the palms and soles and then fire an excimer, because this mineral oil will take care of the scaliness and your excimer can go deeper. Scattering of the third thing which occurs is a scattering. Scattering of light occurs after light has entered the tissue. Scattering is due to the heterogeneous structure of the tissue. Scattering spreads out the light within the tissue, resulting in radiation larger area than anticipated. And it also limits the depth of penetration. But scatter can occur in all direction. It can go and back hit your epidermis also. So it's untowards. Most scattered light is due to interactions with the dermal collagen. And the amount of scattering is inversely proportional to the wavelength of the laser. And that's why a longer wavelength can penetrate deeper, because it has a less scattering. An exception to this rule is laser light beyond the mid-infrared range of the spectrum, because as I already told you, because of the high water absorption, CO2 or RBM YAG. RBM YAG has the highest absorption, if you remember that graph. So it is going to penetrate the least, followed by a CO2, which is a slightly less absorption than RBM glass. So you can still go a little deep, but the depth of penetration is limited, and it's maximum to the papillodermis in a continuous way. And the absorption is the most important and most desired laser tissue interaction. Laser light absorption by a specific tissue target is a fundamental goal of clinical lasers. According to the Grothus-Draper law, light must be absorbed by the tissue to produce an effect in that tissue. If there is no absorption, there won't be any effect. So your laser is going to be waste. And to have this absorption, we have a selective chromophore, which is going to absorb the single wavelength of light. Coming to the laser tissue interactions, laser-induced tissue reactions are dependent upon the parameter of the laser being utilized as well as the target tissue's properties. The laser's power, spot size, pulse duration may be manipulated to yield different tissue reactions. Exposure times determine the ultimate temperature of the tissues, and therefore the most crucial parameter determining which tissue reaction will occur. So light interacts with tissue in a unique ways. The photothermal way, where heat coagulates or cut the tissue; photoacoustic way, where a sound wave explodes the tissue; photoablative wave, where high energy vaporizes or cut the tissues; or photochemical wave, where energy causes chemical or cellular changes. So we'll see that each of these reactions depend on the different pulse duration and the energy density which we are using. So pulses less than 1 nanosecond allows plasma-induced ablation or photomechanical effect, which is seen in picosecond laser. 1 nanosecond to 1 millisecond allows photoablation. 1 millisecond to 1 second allows photothermal reaction, photothermal reaction, and greater than 1 second pulses allows photochemical reaction. This is a very brief and rough idea about this. Coming to a photomechanical reaction, what is a photomechanical or photodisruptive reaction, which we standard used in Q-switched or picosecond laser? A photochemical reaction occurs when a high density of photon breaks intermolecular bonds, such as in such a way that ions are created. These ions or free electrons rapidly expand, creating a shock wave in the cell that fragments the surrounding tissue, the surrounding structure of the cell. To induce photomechanical tissue reaction, high pulse energies with duration of nanoseconds or shorter are used to create high energy plasma. And this is a plasma. Pure photomechanical effect rely on the generation of plasma, which is a process called as optical breakdown. The laser-induced optical breakdowns, LIOBs, which is basically used in picosecond laser in a fractionated mode or using a diffractive lens arrays, followed by a shockwave generation, cavitation, and jet formation. This is used in Q-switched and pico laser. The Q-switch laser is more of a photothermal reaction and less of a photomechanical reaction, although we want a pure photomechanical reaction. A pico laser is more of a photomechanical reaction and then less photothermal reaction. We still do not have a pico laser which produces pure photomechanical reaction. It's an ideal reaction, but for that we required a pico lasers in pulses less than 70 picoseconds. Unfortunately, these lasers cannot be manufactured for medical uses because it produces plasma on the surface of the skin, on the epidermis, and the chances of epidermal burns are there. The industrial part has moved far ahead of these pulse duration. So we get a picosecond laser at 45 picoseconds, or even we get industrial laser in the femtosecond range, which is basically, I think Deca is a master in producing these lasers, and they are used for, the heritage polishing or heritage, whatever they call it as. So it's basically used for industrial use and not in medical laser. So pico, although it is purely, it is photomechanical, we still have some photothermal reaction which can cause skin burns in pico also. A photothermal is the most common reaction used in dermatology. We all CO2s on a part of Q switch laser, hair removal laser work in by photothermal reaction. Photothermal reactions are two-step procedure whereby a molecule absorbs a photon, got excited, and then subsequently deactivate while kinetically activating its neighbor. The increase in kinetic energy translates into the rise of tissue temperature. The observed reaction which depend on the temporary evaluation of the temperature achieved, exposure time, and where you are placing the heat. Different thermal issues such as coagulation, vaporization, carbonization, and melting is possible. And this graph explains what sir has told. The skin temperature is around 37 degrees centigrade, and there is no observable tissue reaction will occur up to 42 degrees centigrade. At 42 to 50 centigrade, this is called as a zone of hyperthermia, which results in conformational changes in molecule and membrane alteration. Up to 50 degrees, these changes are reversible. Most of the bipolar non-ablative radio frequency devices achieved this temperature of hyperthermia, but again, these are, reversible reactions. So you do not get any temporary effect immediately with this, any permanent effect with this temperature. 60 degree, protein and collagen will denaturate, will lead to coagulation and necrosis. So this is our target temperature in hair removal laser or non-ablative skin tightening or a skin tightening device. Because at 60 degrees, protein and collagen will denaturate and there is an immediate tightening, which leads to coagulation and necrosis. But we have to achieve this 60 degree at the depth of dermis. And to achieve that 60 degrees, we have to heat the epidermis to a much larger temperatures, because the epidermis is going to get heated to a much larger temperature. So when we say that we achieve 42 degrees at epidermis, we are actually achieving 60 degrees at dermis. To prevent this heating of epidermis, we need effective cooling, either with cryogen or with the contact cooling, so that the epidermal temperature is kept at a less degrees, at around 42 degrees, because we know that for up to 42 degrees, nothing will happen to the skin. There will be no reaction. But at the same time, you achieve a dermal temperature at around 16 degrees and you will get a skin tightening or destruction, photothermal reaction, which will result in destruction of hair. And that's why every laser should have an effective cooling available with it. At 80 degrees, membrane permeability is compromised and cell chemical equilibrium is destroyed. And at 100 degrees centigrade, water will vaporize and resulting water losses causes thermal properties of the tissue to change at both conductivity and diffused is reduced. So when you use a CO2 laser, the central zone is you vaporize the tissue. When you use a vaporized mode, you are vaporizing the tissue where there is a clean wound. At above 100 degrees centigrade, carbonization can occur. The tissue turns black and smokes, which can reduce visibility during surgery. So when you use a CO2 laser, if you see a black ischar forming on the skin, it is very imperative that you are exceeding 100 degrees centigrade and you are causing carbonization of the tissue. The problem with carbonization, coal or carbon is the heat sink. So whatever laser you are going to fire on this tissue, all the laser is going to absorb here, and it is going to, because carbon, it's an undesirable effect. It is going to pass on this energy to the surrounding tissue, and which is ultimately going to result in a bulk heating. So it is very imperative between the two passes of CO2, you just have to wipe out the skin. You have to remove that carbon if you want to still go deeper, because if you heat the carbon, it's not going to go deeper. It is going to go more laterally. And that's why it is very important. And at around 3, if you still start hitting the carbon at around 300, more than 300 degrees, a melting is occurred, which has no role in dermatologic laser surgery. Once the target is heated, it quickly loses its heat. Loss of heat occurs by heat conduction, convection, or due to blood flow and heat radiation. The conduction is the primary means by which heat is transferred to the adjacent tissue. Laser pulses less than TRT do not allow the heat diffusion to occur because it is diffusion to the distance given by the optical penetration depth, and thermal damage is negligible. Photothermal tissue reaction is mostly commonly used in dermatology, especially coagulation and vaporization. And here comes the extended theory of selective photothermolysis. I asked you to remember the chromophore, the melanin and blood vessels. The pulse duration, the TRT of chromophore is 1 microsecond, and almost for the blood vessel it is 1 millisecond, or the hemoglobin it is 1 millisecond. And we use laser hair removal in the pulse duration of 10 to 30 or 100 milliseconds, and pulse dye laser in the pulse duration of 0.5 to 40 milliseconds. So this is because of extended theory of selective photothermolysis. We know that blood vessel is not our chromophore. Our chromophore is oxyhemoglobin. So we heat oxyhemoglobin, and this heated oxyhemoglobin has to transfer its heat by conduction to the vessel wall to destroy the vessel. So we need something more than a thermal relaxation time. So we need an extended theory. Here the extended theory of selective photothermolysis comes. The principle is thermal damage time. Similarly, in hair removal lasers, we are targeting the melanin, but the stem cells are in the bulge region, which is far away from the matrix. So from the matrix to the heat should travel to the conducted through the stem cells. And for that, we use an extended pulse duration of 10 milliseconds when the TRT of melanin is 1 microsecond. So that's why we used millisecond lasers to use to treat hair or blood vessels. Photoablation, when nano is observed in nanosecond lasers, photoablation is a combination of tissue evaporation followed by expulsion of liquefied material by hydrodynamic forces. It's a very clean process, excellent predictability with a very, very little thermal damage. So to induce photoablation, typically only photons from ultraviolet lasers using excimer. So the excimer laser, which nowadays we use, do not use photoablation. It uses photostimulation or photochemical effect. But the first excimer used in dermatology is used for photoablation. And it is still used in ophthalmology for corneal laser surgeries because there is no thermal effect. It's a very clean surgery. We have a laser now, blue laser, which is available in dermatology also for clear-cut photoablating effect. But this is different from the excimer which we use for vitiligo or psoriasis. Photochemical effect is basically by PDT, exogenous chromophore, visible spectrum with less power is used, and this I'm not going to talk about PDT tonight. So we know about a selective photothermolysis, we know TRT, we know about extended theory of extended thermal damage time, or extended theory of selective photothermolysis. And in Q-switch, we use something similar called as subcellular selective photothermolysis. A traditional treatment is based on the principle of selective photothermolysis, results in destruction of death of pigment-containing cell. As with Q-switch laser, we are targeting melanin, and when we destroy the melanin, the target is melanin in the melanocytes, whereby we're destroying the melanocytes. In response to cell death, inflammation follows because these dead cells needs to be removed and result in repigmentation and recurrences such as in melasma or PIH. The high peak power, ultra short pulse duration, and the flat top beam of a Q-switch laser results in destruction of only the melanin in the target cell, but leaving the cell alive. So you are not destroying the cell, you are selectively damaging the melanin. This is called as subcellular selective photothermolysis. Since fluence used is less and there is no cell death, inflammation and heating is kept to the minimum, which results in less recurrence. And we know that laser toning had changed the way we are using Q-switch. There are many indications such as melasma, photomelanosis, acne, and so on and so forth. So this is an ultrastructural image. This is a melanocyte with its long dendrite, the nucleus, and these blue, violet, yellow, and red dots are melanin in process of transfer to the keratinocyte. After laser toning with a low fluence multiple pass technique, you are cutting down the dendrite to its, the dendrites has been cut off. The nucleus is intact and the melanin which is in process of transfer is been cleared off. So you are just destroying the melanin rather than killing the cells. And this is called as subcellular selective photothermolysis. Excuse me. And this has been described as dendrectomy. To conclude, sorry for the spelling, laser and IPL should be just be considered as drug. It's a high time we considered them as a drug. That is something can be manipulated to ease the burden of those suffering from the skin disease. And we, if you see the newer indications of lasers, that we are slightly shifting from just skin tightening and skin polishing to core dermatology. Unlike drugs, the basic physics needs to be learned. In drugs, we need to learn a basic chemistry. In lasers, we need to learn basic physics for safe and successful application in dermatology. Thank you.
Thank you very much, sir. Very elaborative and very useful talk. This brings us to the end of today's webinar. And before we conclude, I request our Associate Professor, Dr. Ajit Jangon, to deliver the vote of thanks.
Very good evening to all. At the outset, on behalf of Department of Dermatology, Shri Patil Medical College, BLDE deemed to be University, I would like to thank today's speakers, Professor Inamdar sir, Professor Chandrasekhar sir, and Professor Swapnil Shah sir for their wonderful and detailed lectures. Today is a beginning, and we look forward for your continued association in all the future academic activities. I also would like to thank our Pro-Chancellor, Vice-Chancellor, Registrar, and Principal for their continued encouragement in conducting this academic activity. My heartfelt thanks to all the delegates who participated in today's program, and I request their active participation in all the future academic activities organized by BDLA. I also would like to thank our academic partners, that is Deca Lasers Italy and GeoBio Pune, for their valuable assistance in organizing today's webinar. And a special thanks to Mr. Rakesh Pawar and his entire team from Department of IT, BLDE deemed to be University, for their immense support in organizing the webinar. Thank you.
Good night.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you. We'll meet again. Thank you.
Thank you very much, sir. Thank you very much.
Somen.
Yes, sir. Yes, sir.
Okay, good.
Yes, sir.
Thank you, sir.
Thank you, sir. Grateful for everything. Thanks from the team day as well.
Thank you. Thank you.
Thank you, sir.
Shall I conclude, sir?
Yeah.
Yeah.
Thank you, Rakesh and team.